Hello, everyone, and welcome to our module on quality and safety. In 2014, the USMLE announced changes to the Step 1 exam. Specifically, they announced that there would be an increased focus on quality and safety science. Now, I've spent much of my career developing quality and safety protocols for heart failure patients, so I put together this video to introduce medical students to basic concepts of quality and safety. Now, quality and safety science is not going to be a very high yield part of the exam for you to study. So this video is designed to give you everything you need to know in about 20 minutes so that you can go and focus on other things. None of these concepts are difficult to understand, and if you've simply heard of them, they're usually easy points on the exam. In this video, I'm going to talk about three general categories of quality and safety topics. First, we'll talk about some vocabulary you should know. Then we'll talk about hospital quality measurement, and then we'll finish by talking about prevention and safety of adverse events. The first vocabulary term for quality and safety that we'll discuss is a care transition. A care transition is when a patient transfers from one care environment to another. Usually, this is from the home to the hospital or from the hospital to home, but it can also be from the hospital to a nursing home or from a nursing home to home. And we think of times when patients leave a hospital or nursing home as positive things. The patient is better, but in reality, there's great potential for harm to patients when they transfer from somewhere where there's a lot of healthcare resources around, like a hospital, to home where there may be little or no healthcare resources around. Patients need to know things like what medicines to take, what activities to avoid, or when to call a doctor. So, care transitions are a focal point for quality and safety because we know that a lot of bad things happen to patients when they go from one setting to another. Second vocabulary term is medication reconciliation. This is the process of identifying the most accurate list of medications for a patient, including the name of the drugs they take, the dosage, the frequency, and the route. And it's done by comparing the medical record to an external list. And this is often done at times of transition. So when the patient comes into the hospital, we will conduct a medication reconciliation to make sure we have an accurate list of meds. When the patient is admitted to a nursing home, the nursing home will also conduct a medication reconciliation. This is a big problem for patients because many patients take 10 or even 15 or 20 drugs. Getting an accurate drug list can be very difficult, and you can find that there are different lists of drugs the patient takes at one hospital versus the doctor's office versus home. So, this process of med reconciliation is very important for avoiding medication errors. Another term you should know is an antimicrobial stewardship program. These are programs that are usually run out of hospitals, but they're sometimes also run out of nursing homes or other care facilities. And their goal is to monitor the use of antibiotics. So, an antimicrobial stewardship committee is a group of people that will meet once a month or once a quarter, and their goals are to prevent the emergence of drug resistant bacteria and promote the appropriate use of antibiotics. As you know, sometimes providers overuse antibiotics. They prescribe antibiotics for upper respiratory infections or other indications that are inappropriate. If this happens too much in a hospital, the hospital will get increasing rates of drug resistant bacteria. So, an antimicrobial stewardship committee tries to avoid that. So they'll meet once a month or once a quarter and they'll look at the prescribing patterns of practitioners to see what antibiotics are being used and how often. They'll also look at results from the microbiology lab to see if there's an increasing rate of drug resistant bacteria. An SBAR is a communication tool. SBAR stands for Situation, Background, Assessment, and Recommendation. It's a standardized method of communication, and it's often used by nurses when calling a physician about a patient issue. When serious adverse events occur in a hospital and they're investigated, it's often uncovered that the way the nurse communicated with the doctor was ineffective for one reason or another. So, by training all nurses to communicate using an SBAR, it tries to minimize the chance that there will be ineffective communication. So, nurses trained to use the SBAR will start by stating the situation to the doctor, what is happening. For example, the patient has a fever. Then they'll give the background, which says who is the patient. So, for example, they might say it's an elderly woman with cancer. They'll give their assessment of the situation, what the vitals are, what the current labs are. And then the nurses are also trained to make a recommendation, what is needed. For example, I need to know if you want to start antibiotics. And when nurses can effectively use an SBAR, it helps make the communication very efficient and it helps make sure that the doctor has all the information they need to react appropriately. So that's it for vocabulary. Now let's talk about quality measurements. So let's imagine that you have two hospitals, Hospital A and Hospital B. And let's imagine that you want to know which hospital is the higher quality institution. Well, how are you going to do that? Well, in quality improvement circles, there are certain events that occur within the hospital that are considered markers of poor quality. The more of these events that occur in your hospital, the worse the quality of your hospital is determined to be. So, all of these items I've listed on the screen here are measured to determine the quality of an institution. They're all considered markers of poor quality. So the more of these things that you have, the worse the quality of your institution. The fewer of these that you have, the better you're doing in terms of quality of care. A hospital readmission is just what the name suggests. If patient X is discharged from the hospital and 10 days later, patient X is readmitted again to the hospital, this suggests that there may have been a gap in quality of care. So the readmission rate is used as a quality indicator. Now, some readmissions are obviously not preventable. If a patient gets in a car accident driving home, that is not something the hospital can prevent. But other readmissions are preventable. For example, the patient may have been discharged too early, or the patient may not have been educated prior to discharge about what to do once they got home, or maybe follow up with the patient's physician was not scheduled prior to discharge. So, because of all these reasons, if you have a high readmission rate, it suggests you may be running a poor quality hospital, and readmission rates are monitored, especially for certain conditions like heart failure, to determine the quality of a hospital. It turns out that some medical conditions, when they are treated in the hospital, are more likely to lead to a readmission than other medical conditions. And this has been studied extensively in the literature, and I've shown some data on the screen here that it's important for you to understand for step one of the board. So these data are from a study done by the Healthcare Cost and Utilization Project. The reference is at the bottom of the screen. This study identified the most common conditions that lead to 30-day all-cause hospital readmissions, and the conditions were broken down by insurance payers. So let's look carefully at this chart. So among patients who have Medicare for their health insurance, heart failure had the highest 30-day all-cause readmission rate. And let's make sure you understand what that means. This means that if you are a Medicare patient and you are treated in the hospital for heart failure, you are the most likely type of person to have a readmission to the hospital within 30 days for any reason. That's what the word all cause means. So you might come back to the hospital for heart failure, but you also might come back for pneumonia or some other problem. It's all cause readmissions. But for whatever reason, if you had heart failure and you leave the hospital, you are the most likely type of patient to come back within 30 days for a readmission. Second behind heart failure was sepsis, and behind that was pneumonia. Now, the conditions that lead to high rates of readmission are different for other payers. Among patients who have Medicaid for insurance, mood disorder hospitalized patients had the highest rate of readmission, followed by schizophrenia and diabetes. There are many patients with psychiatric disorders in the Medicaid population, so that's why different disorders lead to readmission for this group of patients compared with Medicare. For private insurance patients, those patients treated for chemotherapy had the highest rate of 30-day all-cause readmissions, followed by patients treated for mood disorders and patients treated for complications of surgery. And among the uninsured patients, mood disorders topped the list, followed by alcoholism and diabetes. And the way you are most likely to be asked about these data on the Step 1 exam is you may be asked to identify which type of patients are most likely to be readmitted. And that's what this chart on the screen shows. For each type of medical insurance, this chart shows you which patients are most likely to be readmitted within 30 days for any reason. Pressure ulcers are skin lesions that occur in immobile hospitalized patients. They're sitting on their rear end all day, and there's a high risk of skin breakdown. And this can lead to pressure ulcers that are usually in the sacrum. This can cause pain and it can be a risk for infection. And there are things that hospitals can do to prevent pressure ulcers. They can do daily skin checks, they can use special mattresses that redistribute the pressure, and they can identify these pressure ulcers early and take good care of the skin so that the pressure ulcer doesn't progress. This is a picture of a massive pressure ulcer on a patient's sacrum. This is the type of thing that can occur in a bedbound patient if they're not checked every day. So hospitals are monitored for the frequency and severity of the pressure ulcers that occur among their patients. And if you have things like this developing among your hospitalized patients all the time, it is a marker of poor quality care. Surgical site infections are another quality indicator. These are post-surgical infections. They're usually superficial skin infections like cellulitis, usually around the incision site for the operation. They can also be deep tissue or organ infections depending on the type of operation. And these can result from poor sterile techniques. So if your hospital has a very high rate of surgical wound infections, it suggests poor quality care. Central line infection rates are also used as a marker of quality. This is a picture of a patient with a central line. She has a central line inserted into a right internal jugular vein, and if this is not inserted with good sterile technique, it can introduce bacteria into the bloodstream, and that's called a central line infection. These infections are usually caused by gram-positive skin organisms, usually Staph epidermidis or Staphylococcus aureus. Ventilator-acquired pneumonia is pneumonia that occurs after a patient is placed on the ventilator. So, for example, if you place a patient on mechanical ventilation for heart failure and 2 days later they develop pneumonia, that's called ventilator-acquired pneumonia. And this can be influenced by hospital factors. For example, if you don't elevate the bed properly or if you provide poor oral care to intubated patients, this can lead to high rates of ventilator-acquired pneumonia, and that's why it can be used as a quality metric. Rates of deep vein thrombosis, or DVT, are sometimes used as a measurement of hospital quality. Immobile, bedbound patients in the hospital are at increased risk for thrombus formation. Recall that Virchow's triad is what must be present for a thrombus to form, and Virchow's triad is stasis, a hypercoagulable state, and endothelial damage. Bedbound patients have blood stasis by virtue of the fact that they're stuck in bed all day. Many hospitalized patients have a hypercoagulable state. They may be infected or have cancer or have undergone surgery. Also, many hospitalized patients have endothelial damage. They may have just undergone surgery or they may damage their skin from sitting in bed all day. As a result, many DVTs occur among hospitalized patients, and a high rate of DVTs may suggest poor hospital practices. That's because there are many things hospitals can do to prophylax against DVT formation. Early ambulation of patients helps. You need to get them out of bed and get them moving. Intermittent pneumatic compression are devices that compress the legs to keep the blood moving when patients are bedbound. Subcutaneous heparin or low molecular weight heparin injections like enoxaparin are also often administered to lower the rates of DVT. So once again, if your hospital has a very high rate of DVTs among hospitalized patients, it suggests you may have poor quality practices. Never events are just what the name implies. These are events that should never happen inside a hospital, no exception. Some examples include surgery on the wrong site or the wrong patient. You should never do the wrong surgical procedure. A foreign object should never be left inside a patient during surgery. When you do surgical rotations, you'll notice that at the end of the operation, they count all the tools and sponges to make sure none are left inside the patient. And you should never administer incompatible blood. If these things happen, you can get investigated by the Department of Public Health and potentially your hospital can be shut down. The items I've been talking about up to now are things that are used to compare one hospital to another in terms of quality and safety, but there are things that are done to compare one physician to another in terms of quality and safety. So, for example, some insurance companies will monitor the frequency with which diabetic patients have foot exams and eye exams. And if Dr. A has a very low rate of referring his diabetics for foot and eye exams, they will become concerned about his level of quality care. Systolic heart failure patients are often monitored for administration of ACE inhibitors because they can reduce mortality and hospitalizations, and immunization rates are often monitored among patients and compared from one physician to another. For the last few slides, I've been talking about specific examples of quality measurements, but I want to point out to you that in general, quality measurements fall into one of two categories. They can be either a process measurement or an outcome measurement. A process measurement is a measurement of part of the process of caring for patients that leads to good outcomes. For example, if we measure the rates of immunization of patients in our hospital or the rates of DVT prophylaxis for patients in our hospital, these are not outcomes of care. An outcome of care is something good for the patient, like not getting an infection from immunization or not getting a DVT. Rates of immunization and DVT prophylaxis are part of the process by which we care for patients. They're good things, so we measure them, but they are not outcomes themselves. Outcome measurements, on the other hand, are measuring things that actually matter to patients, rates of infections, rates of DVTs. These are outcomes of care that we want. Now, ideally, we would always measure the outcomes of care. So we would always measure things like infections or DVTs or death rates or something like that that's an outcome of care. However, if we only did that, we would miss all the different process steps that lead to that outcome. Because before you're going to eliminate infections or DVTs, you have to immunize people and you have to administer prophylaxis. So we want to measure the process steps that lead to the outcomes so that we can make sure we get the outcomes that we want. For the remainder of this module, what I'm going to do is talk about some techniques that hospitals and other healthcare institutions employ in order to prevent adverse events. So these are things that hospitals do for prevention and safety of adverse events among the patients under their care. And all these things I've listed on the screen here are things that hospitals do in order to try and make it a safer place for the patient to be. So we'll go through all these in the next few slides. Patients with certain types of infections need precautions taken to prevent the spread of disease, and there are four basic types of precautions used by hospitals. First, there are standard precautions. These are applied to all patients, whether they have an infection or not. Then there are higher levels of precautions used in special circumstances that we'll talk about in a minute. These include droplet precautions, contact precautions, and finally, the highest level of precautions are the airborne precautions. These are also called respiratory precautions or TB precautions because they're often used among patients with active tuberculosis infections. Standard precautions are precautions that are basically applied to any patient in the hospital. This includes good hand washing by providers, gloves if they're going to be touching anything bloody or that contains body fluids, a surgical mask or face shield if there's a chance that blood or fluids might splash or spray into your face, and a gown if there's any chance your skin or your clothing might be exposed to blood or body fluids. Contact precautions are just what the name implies. These are precautions for patients who have certain types of infection that can be easily spread around the hospital by contact. When a patient has contact precautions on their room, you have to put on gloves and a gown anytime you enter that patient's room. The most common places where you'll encounter contact precautions in the hospital are first for any patient who has infectious diarrhea like norovirus or rotavirus. People hospitalized with these viruses can cause an outbreak that can spread through the entire hospital. Clostridium difficile is also a very important infectious agent where contact precautions are necessary. Clostridium difficile infects people who have diminished bacteria in their gut. So this includes people on antibiotics. And there are lots of patients in the hospital on antibiotics. So if one patient develops C. diff, it can be spread around to all the other patients on antibiotics, and you can have a Clostridium difficile outbreak in the entire institution. And then finally, you'll often see contact precautions instituted for patients with MRSA infections. Methicillin-resistant Staph aureus is present on the skin and in the nasal passages. And if a patient develops an infection with this, it can be spread around to other patients, and you can see an outbreak of antibiotic-resistant Staph aureus infections in the hospital. Droplet precautions are for patients who have an infection that spreads by speaking, sneezing, or coughing, usually by respiratory droplets. For patients placed on droplet precautions, you have to wear a face mask in addition to gowns and gloves anytime you enter their rooms. The key pathogen where you'll most likely encounter this is anyone hospitalized with meningitis. Neisseria meningitis, even though it infects the central nervous system, is spread by respiratory droplets. So this typically occurs among college students with fever and neck pains. You can also have outbreaks among military barracks. But anytime a patient has Neisseria meningitis and is in the hospital, they will be placed on droplet precautions. Other times where you could see this are patients with respiratory viruses like influenza or RSV among children. Also, you can see it among patients who have Bordetella pertussis. This causes whooping cough, but you almost never see this in the United States because of immunizations. Respiratory precautions are for patients with infections spread by the airborne route. Now, these infections also spread by droplets, but the droplets are so tiny that the masks used for droplet precautions are insufficient. So providers who enter the room of someone on respiratory precautions have to wear a fit-tested mask or often a respirator, which is a self-contained breathing apparatus. And these are in place to make sure that the provider doesn't breathe any of the air in the patient's room. The provider also has to wear gloves and a gown. You should know that respiratory precautions are often called TB precautions, and that can help remind you that the main time where you'll encounter these precautions are in someone who you suspect of having tuberculosis. So if you admit someone who is immunocompromised to the hospital with fever and a cough, they will need respiratory precautions to make sure that if it turns out they have tuberculosis, you haven't infected the entire hospital floor. Sometimes respiratory precautions are also used for measles and chickenpox, but it's less common for people to be hospitalized with these types of infections. Hospitalization is a good opportunity to conduct immunizations on patients who need them. Many hospitalized patients, especially adults, are at risk for influenza and streptococcus pneumonia. So these two immunizations can be administered while the patient's in the hospital. The indications for the pneumococcal vaccine are age 65 plus or age less than 65 with high risk conditions like heart or lung disease, and almost all hospitalized patients meet one of these two criteria or both of them. There are two vaccines that can be used for pneumococcal vaccination. The first one is called PPSV23. This contains capsular polysaccharide antigens. The second one is PCV13. This contains polysaccharide antigens conjugated to diphtheria toxoid. This one is often administered first because it's conjugated. It elicits a more vigorous immune response, and then this one can be given as a booster. The influenza vaccine is indicated for all persons 6 months old or older annually. It's a killed virus vaccine, and this is generally given to hospitalized patients whenever there's an opportunity. A root cause analysis is a technique used by hospitals to analyze serious adverse events, and the goal is to identify the direct cause of the adverse event plus any contributors. So, for example, suppose a patient was given the wrong drug. This is an example of a serious adverse event. This could be a doctor error, maybe the wrong drug was ordered. It could also be a nursing error, maybe the wrong drug was administered. It's also possible that there were deeper contributors to the error. Perhaps the labels are hard to read. This could be a printing problem. Or maybe the nurse was rushed, so this is a hospital error. They are insufficiently staffing the floors, and this led to the problem of the wrong drug. So all these things are possible causes, and a root cause analysis attempts to get to the bottom of these types of issues. A related practice to a root cause analysis is something called a failure mode and effects analysis. This is a technique that attempts to identify how a process might fail before anything's gone wrong. It's like doing a root cause analysis before the adverse event has occurred. People who get together to perform a failure mode and effects analysis on a hospital or another institution attempt to identify how a process might fail and what the effects of that failure might be. In order to do this, they take a process in a healthcare institution and break it down into its components and then look for the failure possibilities or the effect of failure for each component. So, for example, if you wanted to perform a failure mode and effects analysis on the placement of a central line in the ICU, you would break down the process of placing a central line into its components. So, for example, component one might be position the patient, component two might be to clean the skin, component three might be to use lidocaine to numb the skin, and so on. Then you would try to imagine all the things that might go wrong in each step and imagine what the effects of those errors might be. From doing this, you can hope to come up with ways to prevent the errors from occurring in the first place. Errors that are identified by root cause or failure mode analysis are sometimes broken down into so-called active errors and latent errors. So active errors are errors that occur at the end of a process. In the case of medical care, these are errors that occur at the front line, at the bedside, where the operator makes a mistake. So for example, if a nurse administers the wrong drug, that is an active error of administering the wrong drug. Latent errors, on the other hand, are errors that occur away from the bedside but still impact care. So, for example, if the reason the nurse made a mistake is because there are poor staffing levels and overworked nurses, then that is a latent error. It did not actively cause the mistake, but it contributed to the mistake. And often, when a root cause analysis is done, what you uncover are both active and latent errors that led to the harm that came to the patient. The reason we do things like a root cause analysis when an error happens in the hospital is because usually mistakes involve multiple levels of error. In other words, a mistake is not just caused by the doctor doing something wrong at the bedside, it also happens because of numerous other institutional factors. And this is all explained by the Swiss cheese model of how errors occur in a process. The Swiss cheese model says that flaws at multiple levels need to align in order to cause serious errors. So often it's not just one person who makes a mistake. There are institutional factors, supervision factors, environmental factors, plus individual error that all lead to harm to the patient. So, for example, when you are analyzing a mistake made by a doctor at the bedside, it may turn out that that doctor was poorly supervised. It may turn out that the hospital did not have adequate lighting and that led to the mistake. And it may further turn out that there were other institutional factors at play. So, this is why you do a root cause analysis, because it turns out that in order for a hazard in a process to lead to a loss, all the different errors have to line up to allow that hazard to lead to harm. PDSA stands for Plan, Do, Study, Act, and this is a method of implementing a change to improve quality at a hospital or other institution. So, if, for example, you want to improve the quality at an institution, a PDSA approach would suggest that you first plan a change in hospital practice, then you do what you planned, then you study the outcome to see if things got better, and then you act based on the findings, and then you repeat the PDSA cycle. So, cycles are done over and over, and the point is to generate continuous quality improvement. So, for example, suppose your hospital had too many surgical site infections. You could plan to mandate double hand washing to try and limit the site infections. You would then implement the plan, that's the do. You would then study the effects on surgical site infections and see if your plan worked. And then you would take action based on the results. If the plan was working, you could continue to do it. If the plan was not working, you would try to figure out why, and you would plan to do things differently in the next cycle. And when you work in hospitals and you talk to quality people, you will often hear them refer to a PDSA cycle for a quality improvement program. You should be familiar with the term. A timeout is a pause before a medical or surgical procedure. It's done when the patient, physician, nurse, and all staff are present. Everyone has to agree on the patient's name and the type of procedure, and this includes the patient. So, for example, before a surgical operation in the operating room, the surgeon, the staff, and the patient will all stop. They will list the patient's name and date of birth, and they will state the study that must be done, and everyone must agree before they proceed. And this is a way of preventing some of those never events we discussed, for example, when the wrong patient gets the wrong surgery or something like that. A checklist is a concept from the airline industry. Before an airplane can take off, there's a checklist of items that must be done to make sure no safety procedures were forgotten. In medicine, a checklist is a series of steps that has to be done prior to a medical or surgical procedure. And checklists have been shown to reduce many adverse events. Implementation of a checklist in the ICU can lower your rate of central line infections. Implementation of checklists in the OR can lower the rate of surgical site infections. So many hospitals use checklists to make sure that nobody forgets any of the key safety items before they conduct a medical or surgical procedure. When patients crash in a hospital, meaning they become unresponsive or they have a cardiac arrest, it turns out that those things usually don't occur out of the blue. There are often signs of the patient's impending decline for many hours before the crash occurred. So, for this reason, lots of hospitals have implemented things called triggers and rapid response teams to try and get to patients before they suffer the crash. A trigger is a patient event that mandates a response. So, for example, anytime a patient in certain hospitals have chest pain, this mandates a response, or a low oxygen level occurs, this mandates a response. And these are designed to identify patients before they get to the crash. A rapid response team is a group of providers that responds when a trigger occurs with a formal assessment. So, for example, in my hospital, anytime a patient has a certain event, such as these two things listed on the screen, a rapid response team will present at the patient's bedside and do a formal assessment. They may implement medication changes, they may move them to the ICU, and the goal is to prevent the patient from having a sudden crash because these crashes are often deadly and many patients don't survive the hospitalization if they suffer a sudden change in status. Another technique used in healthcare to make sure people behave in a safe manner is to use something called a forcing function. This is where the system forces an action that's beneficial for safety. So, for example, in many hospitals, you cannot order medications for a patient until you have entered the patient's allergies into the system. This is a forcing function to make sure no one ever forgets to check the patient's allergy. And there are many examples of forcing functions used in healthcare, especially in the modern era where we have electronic order systems. Often you can't enter electronic orders until certain pieces of data like the patient's height and weight and their kidney function and things like that have been entered into the system. One way that these forcing functions sometimes fail is something called a workaround. So, for example, imagine if you couldn't get meds for a patient until the allergies were verified, but nurses obtained meds without using the ordering system. In other words, they had a way to go around the ordering system. There's potential for harm here. And this is called a workaround, and it's a way to get around a forcing function. And it's something that people will start to do if your system has too many forcing functions. They'll start to use workarounds to become more efficient, and you won't get the benefits you expect from the forcing function. Enforcing functions are really part of a larger subject called human factor design. This means designing systems that account for human factors, obviously. So when you build a system and you employ human factor design, you try to think about how humans work and function and how they interact with the system. And if you don't account for human nature, this can lead to errors. So in other words, you can have a perfectly good airplane, but if the airplane doesn't take into account the way that the pilot likes to use his hands and feet, you may have a crash even though the airplane is perfectly good. So, taking into account the pilot's hands and feet and what the pilot likes to do with them is called human factor design. It also plays a role in healthcare. So, some of the processes that fall under human factors design include standardization. So, humans like to do the same thing over and over. So, your hospital employs standardization so that the same procedures are followed everywhere. This will reduce mistakes. If you have one set of procedures on the first floor and a different one on the second floor, this makes it more likely that errors will occur. Another human factor design is simplification. So if you employ fewer steps, this leads to less chance for error. And then finally, we talked about forcing functions. If humans can only interact with the system in one way, this will force them to act with it in the safest way possible or the proper manner. The ultimate goal of all the prevention and safety measures I've talked about on the last few slides is to create within a healthcare institution something called a culture of safety. This is where the employees who work at an institution like a hospital view safety as a priority. In order to achieve this, hospitals need to promote teamwork so that everybody works well together. They need to be open and transparent about safety protocols and safety problems. They need to hold people accountable so that everyone feels that they're not the only one being asked to be safe, but that everyone is being held accountable for safe actions. A culture of safety is supposed to include a non punitive response to adverse events or errors. When an error does occur, you don't want people to feel like they're going to be fired or come after you. You want them to come forward and be honest about their mistake so that the hospital can learn from them. And obviously, this involves a lot of education and training, but this is the ultimate goal of all the safety practices I've talked about in the last few slides. If you can create a culture of safety in your hospital, what you hope to become is what's known as a high reliability organization. These are organizations that operate in hazardous conditions with a high potential for error, yet they have fewer than average adverse events. So, in healthcare, a high reliability organization is a hospital or other institution that consistently and reliably has very low levels of all the types of adverse events we've discussed in this module. And that concludes our module on quality and safety.